Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman. On this show, you'll receive powerful insights and resources for rural surgeons. I'm a general surgeon in Northwest Indiana, and this show is tailored around the nuts and bolts of rural general surgery practice. But you'll find topics ranging from practical surgical tips to a host of others, including rural lifestyle, finance, training, practice models, and more. We'll have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. Whether you're a surgeon, other specialist, or primary care, or simply someone interested in healthcare for rural America, I'm glad you're here. Now let's get into the show. Welcome back to another episode of the Rural American Surgeon Podcast. I'm honored to be joined by Dr. John Robertson of Tomah, Wisconsin today. Thanks for joining us, Dr. Robertson.
Glad to be here. Thank you for inviting me.
We're recording outside at your home. It's a beautiful mustache morning here. So we're going to be talking about all things rural surgery, and Dr. Robertson has a very interesting story to tell. So he is a rural surgeon from the city, urban area in Philly to small town in central Wisconsin. And so why don't we start with that introduction? So tell me just a brief bit about your training and the first part of your practice, and then we'll see how that differs from what you're doing now.
Yeah, so I did medical school at Howard University in D.C., and from there did my residency at Harlem Hospital, and then had the fortunate circumstance of going to the same institutions that my dad had gone to, and we practiced for approximately 3-4 years prior to his retiring, and so that was the penultimate part of my practice was be able for him and I to share an operating suite. Following that, I worked in large metropolitan hospitals in Philadelphia, and subsequently, Philadelphia went through a situation with malpractice in which those rates had gotten to a point that was untenable, and then caused a lot of docs, a lot of the surgeons, OB, ortho, general, to look elsewhere for their practice. So I noted that the majority of them had not returned, clamoring about how difficult it was out there, and therefore thought I would take a leap of faith myself and test those waters. Ended up here in Tomah, Wisconsin. Have been surprised by the many complexities and rewards having come out this way. And it was different both culturally, but also in type of work-life balance. I was trained in both general and vascular, just subspecialty in vascular, and was not performing much of the same vascular surgery that I was trained to do, but was doing more. I'm doing more cosmetic vascular surgery here. However, on the general aspect, I found that I had to broaden my skill set to where there were procedures that I was doing, for instance, C-sections, in which no surgeon in Philadelphia would be doing C-sections. It's all controlled by OB, and doing a lower and upper endoscopy, of which a GI has that locked up in the bigger cities. So there's a certain adaptability that you had to go through in order to in order to make yourself viable in this setting. So it's been challenging, but I've enjoyed it as well. So
how many years did you spend in Philly versus here so far?
So 22 years in Philly, and I've been here. Actually, it's been about 17 years here.
Yeah. So that's a pretty good comparison.
Yeah.
And one question maybe a urban surgeon might be wondering is, you didn't necessarily have C-section training in residency. So how did you get the skills required to come out to a small town and do C-section safely?
So what's interesting is what at that point in time was little known by the administrative staff of of um, of surgeons working in the city, and what we did and didn't do. And they had assumed that I was doing all types of surgery, including C sections, and so I indicated to them otherwise, and, and they asked if I was interested, and I looked at it all as surgery. And I found it interesting because that was kind of like what my dad was doing, because he's of the generation where they were doing all types of surgery, including OBGYN and ortho. Um, and so they took the opportunity to train me at Gunderson Lutheran here in La Crosse, Wisconsin. And so that training proceeded. And following that training, then I was proctored at the hospital. And now I'm doing them, um, individually.
Yeah. So that's interesting that you have the Gunderson hospital train. So you got a spoken hub model that actually works.
Right.
But the interesting thing is you're not really working for Gunderson, but they were friendly enough to give you that training.
Right, because they're which was nice in the sense that their mission is the community.
Yeah.
And they were, nice enough, and in an effort to support the surrounding communities, they allowed that to happen.
Yeah, it's when
which you don't necessarily see elsewhere.
No, a lot of these big systems, they're not the enemy just like the insurance companies are.
Right.
But they're sometimes not helpful, and decisions being made by non clinicians. And really, I believe some people think the world is a pizza, and
right.
I take my slice.
Right.
And that means you can't have that slice.
Yeah.
And the world is nothing like that.
No.
The world is like an oven where we can all bake as much pie as we collectively want to. And if we work together, we'll all do more. We're going to raise the bar in terms of quality, not only quality, but availability and quantity, because there's a lot of unmet need out there. And if we can kind of work together, it's really refreshing to hear that they did that. Now, that was 17 years ago. I don't know.
Well, it's nice that you brought that up, because the fact is that you're right in the sense that this was an unknown factor or unknown concept in the larger cities, because the cities it's basically dog eat dog, and the concept of trying to work together was formed. So it was very strange to see that here specifically, because this hospital, though I work for Toma, there are clinics from both Mayo and the Gunderson system, and they each had their own surgeons, and we all kind of worked together, certainly with call and collaboratively, with difficult cases that would have come up.
Yeah, I feel like there's less competition, but it all is based on, I guess, probably the total amount of surgeons in an area. But I remember I talked to another surgeon about this one time, and I said that I view all of us, especially rural surgeons, as a group of people trying to meet the needs of rural America. And the surgeon I was talking to said, well, I definitely don't view it that way. I was like, oh, wow. So there's other people that have other viewpoints beside mine. And I think the point of that was, no, I think that I have to, maybe I'm the hero. There's that attitude. There's also the attitude of I need to protect other people from other rural surgeons. And then there's the competition. So there's different ways of thinking about it, but I challenge the listener to try to have an open mind. And maybe I'm just fortunate enough that there's so much demand that I don't have to feel competition. The other thing is surgeons are very competitive people in general. Like Enneagram personality profile 3, very common, the achiever or the doer or the competitor, which I actually am. But we were doing an Enneagram personality test recently, and we're kind of diving deep in with an organization that I work with. And I said, I am competitive, and I do want to win But I don't like to beat people. So there's a distinction. And like the
Yeah.
pizza pie baking, I feel like we can all win together and you're going to go further as a team. That's me at my best on a Saturday morning in a beautiful, environment talking with a mentor, but that is what I strive for.
Right. So I kind of follow the same prescription that my dad followed. It was that we're all uh, working to the same end, and that is
Our eventual death.
yeah.
No, just sorry. Laugh so you don't cry.
That is taking care of patients,
Right.
and providing the the greatest access and the best opportunities, and providing the good care to them, and that we are a team. I I will say that I see that more here than I saw in Philly. Um, but like you said, we're all individuals, and we all have different perspectives. But I've always felt the same as you have, and that we work together, and in working together, we're able to provide the best care.
Well, that's beautiful. I had one more question about your dad. Was he still alive when you came here to Tacoma?
No,
Okay.
no. So actually, so when I left Philadelphia, he had passed, and that was the time that I knew that I would take that opportunity to look elsewhere.
Mhm.
Otherwise, I would have stayed in Philly.
Oh, I understand. I was just wondering if he had an opinion on it, but we don't have that luxury to
Well,
ask.
he had told me never to go into surgery. He said he said it's changed so much,
Mhm.
from the time that he was out there, because I remember going on house calls with him,
Mm.
and seeing patients with him that he would see within the community. But
What kind
that's
of patients would he do house calls on?
well,
Like
he was
wounds?
doing medicine as well,
Okay.
so it was a different time.
Yeah. Well, here's the
Yeah.
thing. I've done a couple house calls
Yeah.
in
Oh,
my
really?
practice in Indiana. One situation, they're both. One was a wound and one was a post-op question. And they're both after hours, weekends. Somebody gets a hold of me,
Right.
through. One of them I actually set up because I did a debridement on a Friday. I wanted to look after them before, and I didn't want to. I didn't think they really needed to admit. The patient really didn't want to admit, so I went to her house and did a wound change. And
Oh, wow.
she was obviously very happy. That's in my hometown. And then another time was a patient called with a post-op question, and we were kind of after hours. It's like, do you send them to the ER, or I happen to be in the town where she was
Right.
doing a event thing, and so it was easier for both of us. I just went over there and
Right. Yeah.
checked out the situation, and it did not need admission or anything, so it was provide reassurance and then carry on.
Well, I mean, and there are opportunities for that, and so and that's what I've always found interesting about medicine, is that you know it might not be within the community that you're in, but certainly there are pockets within the nation that you can find um, what you're looking for, or that niche
Yeah.
that works for you. So it's still a big country out there, and
Yeah.
even though it appears to be getting smaller, as a result of insurances,
Yeah.
there are pockets.
Yeah.
So
Well, that's beautiful. I think that pretty well covers things you love about rural surgery. I guess maybe one more thing I wanted to talk about. When I was in training, I did the rural surgery track at Mayo. And so the idea is that I go to a small town like what is currently a critical access hospital in the United States, where they may not have all the specialists, maybe OBGYN, urology, ENT, plastics, whatever they don't have. But there's little pieces, small, easy, I hate to say it, but easier cases with lower morbidity, mortality type things, such as carpal tunnel, such as vasectomy, where you don't really have to be a ortho or neurosurgeon to do the carpal tunnel. There's a large volume of it. You can do them safely, and people don't have to leave town. And so my track had dedicated rotations in those 5 things as a 4. So I was already essentially a surgeon that could do cases by myself by this point, which is the nice part. And then I went and I did these rotations at a place where I could also flex out of that rotation into general surgery the whole time. So it was really nice. But I had ortho, urology, ENT, plastics, OBGYN. At that time, I didn't know the incidence of all these things, and how important each individual thing would be relative. But you pointed out two things, which is exactly what I found are the two most in demand out of all. So will be C-sections and scopes. Those are the things that are needed, and that's 80%. The 80-20 rule, the Pareto principle. 80% of your value comes from 20% of the stuff. That's the 20. That's the 80-20. I did an ENT rotation. I came out thinking that I would be able to do parotids, for example. There are no parotids out there. There's one every 10 years. Why would you bother, doing that? Even like the thoracic stuff. I came out very well trained to be able to do VATS. I did some early on. I just transferred a patient because the hospital is not comfortable doing VATS. It's just spontaneous pneumothorax and probably needs a blebectomy and a pleurodesis. But at the end of the day, if I come across one of those every 2 to 4 years, versus, 500 scopes a year, where's your value to the community?
And as you state, those are the two biggest, but just to indicate to you, there were other, just like you stated, doing vasectomies or doing, I found myself even doing tubal ligations. So there's still a need for those little, minor procedures, but very different than what I was doing when I was in Philadelphia.
It's beautiful. All right, so let's move on to the how I do it section, which is my favorite part of the show. And if you're a hospital administrator or a family practice doctor listening, you can feel free to skip ahead. If you're a resident, then turn the volume up. So we're going to talk about a case I haven't talked about yet, but that I love, obviously, open inguinal hernia.
So my approach to open inguinal hernias is usually the use of a what I call a modified plug and patch, and it was taught to me by Dr. Keith Milligan at Rush University in Chicago. It's where, and and that was derived from Liechtenstein with regard to a tension-free repair. And so the approach is, as most, is through a approximately 3.5 by 4 centimeter incision along the inguinal ligament, between the ASIS and the whatever side you're working on, corner of the pecten pubis. Taken down through scan subcutaneous tissue to the level, through scarpers to the level of the external oblique. Opening that, with your knife blade, taking that both proximally and then distally through the external ring. And then identifying the cord structures, placing a Penrose drain around those structures, and then kind of identifying whether this is either a direct or indirect. Looking for the sac medially, and identifying that sac. What was different than what I used to do when I was in residency is that we were no longer dividing that sac and tying it with 2 silk sutures. We're now just, because it's felt that that's where a lot of the pain comes post-operatively. So the sac was kind of stripped from the spermatic cord and placed within the preperitoneal space for an indirect. And I would then place a plug, large plug in that preperitoneal space, and then use the leaves of that plug and secure that with a 3/0 vicryl to the lateral border of the iliopubic tract, and the sphincter mechanism, which really included the medially would include the internal oblique aponeurosis. Once that was performed, then I would put an onlay patch. Did not secure it except for the wings of that patch or in recreation of the internal ring. And then would then close in an anatomic fashion. Now, if it was a direct, I would use an extra large plug, and then that plug I would create through transversalis fascia an entrance into the preperitoneal space and place that extra large plug, and I would then secure that with a 2-row suture. And in securing that, following which then I would apply the onlay patch and then go through in a reverse fashion anatomic closure using a 3-0 Vicryl and then 4-0 monochrome PDS for skin and Durobond.
So what I love about this is there's so many ways, you have these big studies that say lap versus open or whatever, but there's so many ways to do an open inguinal hernia.
Right.
so how do you do these types of studies? I don't really understand, but there are several little things I'd like to dive in really deep on. So first off, just when you're getting started and you're going through the external oblique, you said you open that with a scalpel. Then do you extend it with a Metz or you extend it with scalpel?
So it's extended so the opening is with the scalpel.
Is it a 15?
It's a 15.
Okay.
And then I'll take a Metz first to kind of like sweep underneath to kind of get the nerve from underneath the aponeurosis, and then I would guide the needle both proximally and then distally through that external ring.
Next question: how do you manage the nerve?
So the nerve, I will sometimes then put a vessel loop around the nerve, or I would take straight clamps or either side of the external oblique aponeurosis and put the nerve behind one of those straight clamps to have it placed outside of the surgical field.
Yeah. All right. So, what do you do if the nerve is really ratty or in your way? What would cause you to resect the nerve? I guess, and we're talking ilioinguinal nerve for the residents.
Right. It was right. Correct. And if the nerve is ratty, I would just divide it. I know some people were talking about tying it, but sometimes I've seen patients develop a little neuroma at that site, and so I just cut it, and I haven't had any issues as a result. But when you're speaking with the patient and talking to them about the complications that can occur, chronic pain is one, and what I would do if chronic pain would arise is then some people do send them to a pain clinic where they'll use RFA to kind of deaden that nerve. What I used to do is apply Kenalog to that area, and that would essentially do the same thing, but chemically.
So you're trying to find a point area of tenderness?
A point area of tenderness that the patient would state, that's where I'm feeling the pain.
Did you ever do a test, like with just local?
Yes, I would.
Okay. And is that on a separate day?
That's on a separate day.
Okay. So then you do that local, and then some of those patients ever just not have the pain come back, or did they always pretty much have it come back?
Some patients that resolved the pain issue, and they never came back.
Yeah.
Right.
But then if they did, and it was the same point, you kind of described it as well as you could in your note to remind yourself. They come in, boom, right here, then Kenalog, and that cleared. I've also heard alcohol ablation, but I've not personally done that. But we used to refer that in residency to pain as well, or anesthesia.
Okay. Gotcha.
They would do that. All right, and basically not operating again if they're having chronic pain.
No, that's correct. Not at all. Don't fall into that trap.
Yeah. All right, so both of these pieces, the plug and the patch, were made out of polypropylene.
Correct.
Okay. And you said if you had an indirect, you put the plug in, then you put the patch, but you did not secure the patch. Is that right?
That's correct.
So you don't stitch it to the shelving edge of the Poupart's ligament. You just let it be there?
Just let it be.
Okay. What if you have a really big direct defect and it's just like it's just in your way? Do you ever do a Bassini or something underneath the patch?
So like you said, there's a lot of ways to address it. Yeah. But yeah, usually because I was trained in Bassini, and so that's what I would ultimately do.
Use Ethibonds for that? Do you use Ethibond sutures for that? Or if you were going to go do a Bassini?
No, I still use. Yeah, I would still use. Well, for Bassini, I would probably use Proline.
Yeah. So I've had that situation several times. Sometimes you got that direct defect that's discrete. So maybe I should just do a real quick direct indirect thing.
Yeah.
So, your abdominal wall is fed with 4 vessels, your 2 paired deep inferior epigastric vessels and your superior epigastric vessels. The superior epigastric vessels are the termination of the internal mammaries superiorly, and inferiorly coming off of the iliac femoral area, the deep inferior epigastric branches up. If in medicine, if there's a deep, there must be a superficial. If there's a superior, there must be an inferior. Otherwise, we wouldn't name them that way. So you can kind of keep that in mind. So the superficial epigastrics run through the subcutaneous tissue in this area. Sometimes they're in our way. Sometimes we ligate them. Sometimes we can push them to the side, whatever. But we're talking about the deep inferior epigastric vessels. And those branch back up off of the groin and then feed the inferior abdominal wall, sort of one vessel going to each quadrant, which also explains why the belly button is the true watershed area. That's the central area where all of these would kind of converge, and it's sometimes made the problem for hernias and recurrent hernias, in addition to the fact that the umbilical cord traveled through that area. It's also the last end for vascular supply. But I digress. So traveling lateral, always the spermatic cord or the round ligament always travels just lateral to the deep inferior epigastric vessels, and that is a landmark you can count on. And if the most common type of hernia in a in all comers is an indirect inguinal hernia, which travels along that natural area of weakness, comes out just lateral to the deep inferior epigastrics. So whether you're an 85-year-old woman, whether you're a 4-day-old preemie, the most common hernia is an indirect hernia. Old man, old woman, young, it doesn't matter. The relative importance of other types of hernias are that an older woman obviously has more relative risk of having a femoral. An older man relatively has more risk of a direct hernia. So I like to say MD, that's my mnemonic for remembering direct. So medial direct. So if it's medial to the deep inferior epigastric vessels, and there's a hole coming out there and a sac, which is your peritoneal sac, that is just a blowout of the inguinal floor. There was no natural area of weakness there. It's just years of chronic lifting and losing muscle mass, and it just blew out the floor. Sometimes that's very discrete, a small hernia. Sometimes it's the whole area is just like weakened and blown out. And so that's what I'm describing is that you find yourself in that situation. Maybe there is or isn't an indirect component. If there was both, we would call that a pantaloon hernia. But in that situation, one thing that I commonly do, sounds like you sometimes do too, is a Bassini repair, which is a suture repair underneath my patch. I've done that several times with good success, and it gets everything out of the way, and then you can do your open repair over the top. Now, tell me realistically, patient comes in, say it's a man, 60 years old, and it's not all the way big, huge thing down in the scrotum. It's like a small to moderate sized unilateral first time inguinal hernia, primary inguinal hernia. Are you going to do what you just described on that patient, or are you going to use any other type of lap or minimally invasive approach or anything like that today?
Well, today mostly I'm doing robotic surgery.
Yeah. So here comes boom, the mic drops. All right, very cool. Okay, so for me, I'm doing, if it's a unilateral man,
Right.
first time hernia, I do them open.
Okay.
For bilateral, for recurrence after open, or for a woman in the absence of any contraindications, I take those lap. So that's kind of my practice, and I don't hold super like hard and fast to it. If a patient comes in and they say, no, I definitely want you to do lap, I talk to them about all the things I normally explain, and if they really want me to do that, I don't think it's wrong, and I would do it. But if they left, a lot of times they say, do whatever you want, and I was like, well, if it's me on an island or in a vacuum making the decision, this is how I'm going to decide to do it. But it's not wrong to go straight to minimally invasive. So we don't need to talk extensively about the robot, but maybe just why are you choosing to do that now more than the open approach?
Right. So I went through the stages just because I've been around a long time. And so I was doing mostly open. And then it was laparoscopic that everybody was talking about. And I actually continued doing open because at least in Philadelphia, no one really cared. Um, However, when I got here, there were more people that were interested in laparoscopic. So then I started doing more laparoscopic surgery or inguinal surgery until we got the robot. And the robot now is the latest and greatest, and I believe will become the standard of care. But again, the interesting thing about surgery and what I enjoy about surgery is there's so many different ways to do the procedure, and you might find yourself there are periods when depending on whether the patient's already had a prior procedure, that you may go back to an open. So having that experience is valuable. And however, I'm in a point where um, I love the robot, and any surgery that I can that I can find that I can do the robot on, then I will be doing that.
Why? What's the best things about the robot that you like?
Well, nice thing about the robot is dissection is very clean, and what you do is if you've done inguinal hernias, no one inguinal hernia is the same, and but by performing it robotically, uh, there's uh, when you're doing it transabdominally, um, it's the same structures in the same area every time.
Yeah.
And I just like that aspect of it. I'm not there's no traps, there's no hidden. The core structures are right there, and you know the areas to go to identify whether you have an indirect, direct, or femoral herniation.
Yeah.
And
I got another question for you. Say you got a big inguinal scrotal. So you do those on the robot?
I I will tell you I've done them both.
Okay.
And but obviously I'll try to reduce it before I do it robotically if I can. But my robot is a fairly recent thing, and so my go-to for if I run into trouble is always the open aspect of it. But yes, would I attempt it? Yes, I would.
Yeah.
And I've been successful doing it.
I remember this case as a chief resident, 3 a.m. Incarcerated, left inguinal hernia, containing sigmoid colon, underneath a rigid fem-fem bypass graft, with a sigmoid colon cancer inside the incarcerated and threatened sigmoid colon. That's definitely my craziest inguinal hernia story that I had. Of course, I did that one open, but it ended up being, groin and midline incision, and then bowel resection and everything.
Right.
And that was one of my few patients in residency that got the ability to continue to have long-term follow-up with. He was so happy, and so that get the cards from the family and everything. Actually, great outcome because good lymph node harvest, no lymph nodes positive. He's cured from so many angles. That was just a fantastic case. But the thing is, end of the day, in 2024, I feel like you have to have more than one way to fix a hernia.
Yeah.
I mean, that's how it. So if you're a resident, you just what's your program like? So whatever you're not getting a lot of, you tend to sometimes do more of the things you already know because you're feeling comfortable.
Right.
You want to do the opposite. Put yourself out of your comfort zone as much as possible, especially when you're a trainee, because especially if you go to rural surgery, it's you're the guy.
Yeah, you're the guy.
Who are you going to call?
You don't always have the assistance or the help.
Right. So you have to be ready. All right. I have one more question. Have you ever heard of anybody doing an open inguinal hernia followed by closing and doing a laparoscopic hernia right after? The same case under the same anesthetic?
No, I have
Me
not.
neither. Okay, but carry on. Speak louder into the microphone. No, I'm just kidding. All right, that's a beautiful one. Let's move on to this next section of our show called the Financial Corner. So is there any money tip, big win or loss that you've had in the past that you'd love to just, clear the air?
Well, I would say, look, I knew nothing about the business aspects of medicine except for what was imparted to me by my dad. But I will say to you that if with the money that you're generating, get yourself a good advisor, um, um, that you're putting your money away and thoughtfully, um, and you're going to be tempted to do other projects. And I would say each project in and of itself should be looked at as being able to maintain itself and never take good money and put it after bad.
That's beautiful. How does someone find a trusted advisor? How do you know they're good?
From other individuals.
Get a referral.
Yeah, get a referral.
Okay, very good. That's beautiful. Classic rural surgery. This is a segment in the show where we tell a story that is just so classic rural surgery. Do you have anything like that?
Yeah, so I will tell you. So COVID was hard on everybody, and so we were finding ourselves in a situation where patients were ending up in our emergency room that normally would not be seen in a rural setting. And we had this individual, middle-aged guy who fallen off his bike approximately a week ago, who presented to the emergency room complaining of pain, but nobody realized how serious he was, because, in fact, after CT, they had noticed that he was bleeding from his spleen. And at that point in time, there was a mad rush to try to get the patient transferred. But all hospitals in the area were dealing with the same thing, and that was staff being out, um, uh, or so not therefore having enough staff to for hospital, to maintain their departments, and therefore being on diversion. And this was not a surgery that was being performed at our institution. And we tried the entire state and even outside the state to try to get the patient transferred too. Unfortunately, you can be put in situations that you don't want to be in. And we were actually the last salvation for this patient. But fortunately, I was in a trauma residency, and
Sure.
so there are things that you don't forget. And so we ended up taking this patient to our operating room and performing a splenectomy, and the patient did well. So we were fortunate in that sense. But those are the kind of things that can happen in our rural setting, especially after kind of the devastation that the COVID had actually presented to a whole lot of institutions in our country.
How would you handle that in like a non-COVID, non-divert setting? So there's a couple things that can happen. Air transport can be unavailable due
Right.
to low ceilings,
Yeah.
for example. And it depends how hemodynamically stable the person is. It's one of these funny things where you get like a GI bleeder,
Right.
and then the GI doctor says, well, they're stable enough, they're hemodynamically stable, so we can, prep them and scope them tomorrow. But if they're not, they're hemodynamically unstable. Well, they're too unstable to do scope, so
Right.
you really need to resuscitate them and do the scope tomorrow.
Right. Right.
So,
Right.
so what if, say, there's no air? It's not has anything to do with COVID, but you're going to have a couple hour ambulance ride,
Right.
2 hours, and you have a shattered spleen and hemodynamically unstable in your ER. I mean, doesn't that still have to go in your institution now or not?
I mean, I would tell you that they would do the best they could to try to get that patient transferred because, again, in our institution, anesthesia is involved, and they're not used to that, and so that's kind of what you're dealing with is just the fact that these aren't common procedures, and so nobody wants to kind of tackle it. We do have the experience, but even sometimes, despite the fact that we're able to do things just like you found with the VATS, um, uh, there is a reluctance to do much more, and that they would actually, as long as they could transfer the patient will be transferred.
Yeah. It just depends. The rural surgery is not all the same. Whether you're here in Wisconsin or where I'm at in Indiana, very similar.
Yeah.
You've got full spectrum, 2 hours away. Actually, I've got an hour away, ICU beds, and then 2 hours away would be like Chicago, Indy type thing. But that's very different than Alaska, Canada areas. I had Lauren Smithson on. She's in Newfoundland, and she's 11 hours by vehicle or 2 hours by helicopter. I think she said, or 2 hours by fixed wing, 3 hours by helicopter. Like, she's going to do that case every time because you just can't take the risk of transport.
Well, the other thing too is blood product too, is the availability of that. And again, we're lacking in that instance as well.
What do you have? 2 units?
2 units.
2 units of ONEG, basically.
Right.
Yeah. So these are the resource limitations we're talking about all the time in the echo chamber that is the Rural American Surgeon Podcast. But, we're not necessarily solving all the problems this morning, but we're definitely delineating some of the issues.
Right. Yeah.
So the last thing is a segment of the podcast, the resources for the busy rural surgeon. So what is something that you found to be really useful as you came to a small town? Because there are resource limitations that has been in your pocket and on your phone, whatever, that has helped you to kind of stay current and in a tight pinch.
Normally mentorship and up to date are the two that I use the most. We do have a collaborative effort here at our institution with the other surgeons that are here, even with locums, and so we value that, and are actually proud of the fact that we've been the surgeons we've been able to work to look to are just as eager to help.
Yeah,
and so that's been valuable to the community.
Well, you've been a great resource for me. I've really appreciated the opportunity to scrub cases with you.
Well, thank you.
And it's just been a pleasure. I've heard,
and likewise.
Well, thanks. Yeah, I've heard what you're saying about mentorship and just fighting that professional isolation from so many people that I've interviewed so far. You're also in the middle of recertifying.
Correct. Yes. Yeah.
So this is sort of a resource, so sort of a burden,
Yeah,
but
a double-edged sword.
Tell me, so you've taken the recertification twice. This is your third?
This is my third, yeah.
This is your third, since they went to the new every other year model.
Right.
And so they're sending you 100 articles to review.
Right. Now, they've reduced that this year to 40.
Okay.
So thank God. We peruse those 40 articles, and then you're getting 40 questions regarding those articles, because they've divided it into sections. So there is a core section that everybody has to do, and then the other sections are either dealing with breast, oncology, alimentary tract, and then a comprehensive abdomen.
But there's no questions about carpal tunnel or C-section, right? See, that's the ironic part.
No, there are none. Yeah, that's correct.
So, and me, I mean, I don't know if you were in your practice in Philly, were you doing esophagectomies or Whipples or liver resection?
Esophagectomies and liver resections, yes.
Yeah, sure. Yeah. But I mean, I would never do those in a rural setting. I don't have the resources, but yet I'm doing other things that are outside of the, doing some plastic stuff. I'm doing, ganglions and carpal tunnels and trigger fingers.
Right.
and things that I wouldn't. A lot of skin cancer, and they don't talk about skin cancer besides melanoma, but it's very relevant. It's every day I'm taking care of basal
cells, squamous,
So this is the world that we're living in, and it's a little different than the city, sometimes quite extremely so. But I appreciate you kind of detailing some of those differences for us. If you had any advice, this is maybe the last thing, for the urban surgeon that maybe is crispy burnout or sick of the competition, and maybe they're considering doing what you did. Would you do it again? What should they think about? How did they make that decision?
Right. So speaking personally, the decision to have done this was made for me, in the sense of where Philadelphia was at the time. However, knowing what I know now, I wouldn't hesitate to do it again, based on the fact of, and it may be just specific to where I'm located, but I have, there is the camaraderie that I have found, the fact that your work-life balance is way more doable, and it's not the chaos that I was used to when I was in the urban setting, and it's more controllable, and if you have a system that's willing, like mine was, to bring in a robot, you're still practicing cutting edge surgery, for which I'm very thankful. The other thing is that you in Philly, you knew you were making a difference just because you were helping people, but here you can actually see the difference because some of the patients that you're working on are actually your neighbors, and that's a different kind of feeling, and these patients you're likely to see in the grocery store or when you're at the pharmacy. So it's you had the fact is that you're still can enjoy this experience because you're still helping individuals, and which was my purpose in going into medicine, and and a sense of fulfillment, and you're also because of what we know as being health disparities in our community, especially minorities and rural communities, you are helping or creating a solution for the problem, and I'm and as far as their access to medicine via the fact that now they don't have to go out 40 miles to get their care. Their care is within the community, and so the economic impact of that is good. And I do believe that our interaction with the community helps with their understanding of their disease process, and that they become more in tune to hypertension and to diabetes and to the aspect of screening colonoscopies, because you're living there, you're within the community, and you also have the you're impacting the community because of the size is way smaller. I mean, this is a community of 10,000 versus working in a community of 4 million. So or 2.5 million in Philadelphia.
You feel somewhat more replaceable. I mean, you are more replaceable in the city than
you are.
See, that's how you can see your impact.
So you have a valuable you're a viable member of this community, and you can provide education that you to this group, and the hope is that leads to people seeing us in the community and wanting to do something like this themselves.
Right.
Because the hardest part in this community is trying to keep people here to maintain rural practices. And so I think that in a lot of aspects you're growing your community and helping it.
I'm inspired. Don't be part of the rural brain drain. Be a rural surgeon. You heard it first here with Dr. Robertson. So thank you so much again for joining me on the show. I really
Thank you
appreciate
very much.
it.
Thank you for having me.
This has been the Rural American Surgeon. Don't forget to share this with the surgeons in your life or anybody that has an interest in rural healthcare, rural practice. We really are glad that you're here, and I'll see you on the next episode of the Rural American Surgeon. Thanks.
Thank you.